with the same structure as frequent factors in the national health system. There is a limitation in the posts of GPs or general pediatricians for settling as principals. So now we can only vacancies can be refilled with new GPs who have to attend the vocational training 3 years. We work on a capitation-free basis with some incentives, and patients can freely choose their GP and change him or her anytime they want. And any GP can have a maximum of 1,500 patients. From 8 p.m. to 8 a.m. and on weekends and bank holidays, a deputizing service and out-of-hour service is on duty, always part of the national health system, while depending on regions, we have also an emergency and emergency service run by regions, not by the national health system, with a E&A doctor and a nurse and an ambulance always available 24 hours a day. Note that doctors working at the advertising service are not GPs. There is debate. Maybe the government would like, or in the national health system, would like to integrate GPs in the advertising service, but GPs don't like this proposal. The national contract states the overall general and overall regulations, but more and more after regionalization in Italy, regional agreement for general practice has changed and made many differences in running GPs in different regions due to local needs, issues, and policies. So that at present, in many regions, there are far largely different organization, planning, tasks, and funding for GPs, even if the national agreement is always, I would say, the umbrella under which different regional contracts exist. Also in Italy, as everywhere, the core content of our everyday job is chronic diseases and multimorbidity. We would say that everybody is aware that only GPs can manage such health problems with a multitask, holistic, continuous and systematic approach, the only one which can guarantee efficiency, cost, effectiveness, which is the alternative. In our country, the alternative is hyper-medicalization, is increase of expenditure, is lower cost effectiveness, and we would like to say also lower quality overall. This is not a figure from Italy, but more or less older than 65 years and more or less 98% have a kind of multimorbidity problem. And 60 million becoming in 20 years, 80 million of American citizens will be part of the multimorbidity problem. This is an example. A man treated at the specialist clinic in the previous 2 years got there 54 times for consultations, diagnostic tests, and treatment. The equivalent of 1 day every 2 weeks was devoted to this work. What are we doing in Italy? The Ministry of Health is always announcing, shouting that chronic care must be based on general practice. Actually, at the same time, funding is still going mainly towards hospital, where actually cuts have been done. But I would say some small hospitals have been closed up. See this one? Some beds have been cut as well, but I would say more passively, because forced by money limitation, than actively, because planning a new system with a more rationalized hospital scheme. We must also say that the ratio of public to private hospital in Italy is more or less half and half. Even more, from central Italy downwards, more private towards public. And you must know that private hospitals are paid by the national health system exactly as public ones. We have also still a question of accountability. It has grown more and more, but we must say that there is a wide variety of behaviors, professionality levels, and professional responsibility by GPs. And this is an important issue in the development of future general practice. In the last 20 years, many group practices have been set up everywhere. Not enough, probably. Many networks have been established because the national health system approves networks, informatic networks between doctors working in different premises, but with their computers connected. And still there are enough doctors working in solo practices. I would say enough too many. But this is a very slow problem. Because most doctors, most GPs work in rented or self-owned premises, not in public premises. There is also a wide limitation of staff and diagnostic services availability in general practice in Italy, because this is not funded or only in a small, very small part by the health system. And so, for example,
what do you mean by direct pay? So I can understand.
Direct pay. If you employ staff, you get only a very small percentage of what you spend by the health system. The most of the money you need to employ staff is paid by yourself, by the GP.
This is direct.
Directly by GP. Well, the tendency and the announcements, you know, my dear friend Enrique Bolda once said, in Italy you're very special. It takes 99 years to open something new and 99 years to close up something old. So they are announcing, they are working, we are going towards more and more aggregated practices, and this is the future of general practice. With direct integration with out staff in the same practice. Well, in different regions, due to regional agreements for general practice, there are different ways of understanding and inventing and applying general practice. What we try to do is to show the two examples of our two regions. We are in Bologna. This is the yellow is Emilia Romagna region. Angelo lives in Firenze. Here, see the red dot. This is my region, Lombardia, capital. City is Milano. I live here. See the red dot, and border with Switzerland. So, two close regions, one to the other. Two very different kinds of interpreting and planning general practice. Angelo will tell you about the House of Health, Casa della Salute. I just want to say that they are, in my opinion, a kind of more social approach to general practice, to primary care. I want to tell you something about what's going on in my region, Lombardia. Well, very synthetically, in 2011, the region has
Disco kaput.
Angelo, it's very simple. The region has set chronic diseases, say diabetes type 2. The region has said, well, I decide how much money I give you. How I decide the protocol, that is, you have to perform twice a year a glycosylated hemoglobin to each diabetes patient. You have to check fundoscopy once a year, ECG once a year, and say check food examination once a year. Well, you have to organize a call center 24 hours a day. You have to organize a kind of continuous care 24 hours a day. I give you such and such if you take care of 1,000 diabetes 2 patients for 1 year or for 2 years. An auction, a clear auction. So, now in the last 2 years they are experimenting in very small part of our region this kind of approach. I would say not very social. And we don't know how it will go, but this is the structure of the approach to chronic diseases by Lombardia, which is the richest region in Italy. Which is the problem for GPs? One, first, to apply to this auction is a clear auction. You have to be very well organized. So in Lombardia, for example, you have to set cooperatives with GPs. One has been set to apply for experimental auction for diabetes, and they have gathered together 200 GPs. But it's not easy for GPs to organize and to fight against large hospitals as well as large private health organization. And if this will go on, probably the risk is lower professionality for GPs, because some GPs will be thrown away from dealing with chronic diseases. And there is also a kind of risk of abdication, because no incentives will be provided for solo GPs. Well, the other problem is that in many hospitals, clinics, dedicated clinics for example, diabetes, hypertension, arthritis, have been opened, and they overlap with GPs to conquer new territories. What's the result? A strong fighting in some areas, application by GPs in some other areas. For example, in this region, they are trying GPs are trying to cooperate with some of these hospital-based dedicated clinics. What about quality and limitation of resources? The central government has reduced money transferred to regions. Once the central government used to pay debt done by regions, they don't do anything anymore now. People must pay money to get services. For example, say 36 euros in my region for a lung X-rays, and the quality has gone down while waiting lists has gone up. Vacancies in GPs are not replaced, so increasing the number of patients per GP, we got a more or less 20% cut, depending on regions. Programs of clinical governance have been cut. There were incentives for GPs to be involved in dealing with taking care of chronic diseases, and there is a strict control on drug and specialist prescriptions by a benchmarking system. We get reports and with the benchmarking with our district and with our region. We have still two main hospitals, but what is, in our opinion, what are the main problems is first, the lack of clinical protocols and guidelines shared with specialists. They exist, but they are not applied so frequently because they are mainly not shared with specialists. And there is no strict quality control in general practice and, of course, also in hospitals. Well, I finished. After Angelos, we would like to ask you how the problem of resources limitation we cope with in your countries, which are the ideas we could share, and we try to then debate something together. Thank you.